So this is...
I think NHIF is making very many claims about what this scheme is going to offer its members, and without having actually the means to back it up. The amounts that we've been told that would be paid to providers would be on a capitation basis, which means that they're paid per person per year to deliver what NHIF has promised. But the amounts range from 500 shillings per person per year for a small clinic to a hospital like mine would get 1,500 shillings per person per year to deliver all these services. And no hospital can possibly do such a thing. So to tell the members they're going to have full cover and all of their chronic conditions will be covered and they will have unlimited visits is just not being straightforward.
What exactly are you offering?
Look, when we say that we will do capitation, first of all, we are going to ask our members to register to a facility of their choice that is nearest to them. And in so doing, the number of members who will register, then we will capitate. And when we capitate, agreed, part of the risk is transferred to the provider, but the fund also still has the risk. And you will find that if you have 1,000 patients who have registered with you, not all of them are sick. And you will find that in that process, you are bound, if you look after them well, you are bound to make ends meet. But if you don't care about them and you ignore the choice, then you can make a loss. So the basis is that I will be able to visit the doctor as and when necessary, and that if I have an ailment, like a fever, I will go for a checkup. If I am a lady and I want antenatal checkup, I will go. If the doctor recommends an X-ray, it will be given. It is true, it can work. There is a basis, there is a scientific evidence, it has been done in other countries. But the high-cost hospitals, it will not work. So if you go to Nairobi Hospital, what we will pay is not enough to take care of you. That is true.
Well, the biggest part of any expenditure for patient care, of course, is the drugs. And those are pretty much the same, whether it's a government hospital or a mission hospital or a high-cost hospital such as Nairobi Hospital. And that constitutes, for most of us, about 45% of our expenditure, just the drugs alone. Now, to say that there's such a difference in the cost of medical care between mission hospitals and other private hospitals is not quite true.
Are we saying, though, that the quality of healthcare that you will get in the government institutions or in the mission hospitals, that's what you're recommending, will be at par with what is available in the private institutions?
Essentially, it will be at par. As we talk now, walk to any mission hospital, a pregnant lady will go there and get a baby, and the fund pays 5,000, and they go home. It is happening now. If she requires a cesarean section, we pay. It is done, and they go home. It is true, you can go and check. But if you go to Diana's hospital, then she'll probably demand a higher figure, and that is true, we cannot pay. But what the consolation we have is that 90% of Kenya's population does not seek care in the high-cost hospitals. They seek care from the public facilities, they seek care from the mission hospitals. And for us as a fund, as a social health insurance fund, we are targeting the majority that will get care.
You're targeting the majority, though, but your members for 2009 were 2.3 million.
Yes.
That is out of 40 million Kenyans.
Yes.
38 as per the current statistics.
Yes.
So what happens to the poor of the poor?
Well, you see, once you target the 2.3, we have proposed to continue to build membership as we move, as we offer the cover, and as many Kenyans begin to appreciate what NHIF does, they will register as members. And we believe we will move the percentage coverage from the current 22% to 30-35%. We don't want to say that within the short time we will cover 100% of Kenyans. There will still be a gap. There will be the indigent whom the fund cannot cover. And this is what we have said that there will be engagement with different stakeholders, including the government, as part of social protection to be able to find a mechanism to cover the poor who are not able to pay their premium.
Diana, your concern first of all, as you talk there, is that perhaps what NHIF is saying it will do, the situation on the ground is vastly different.
Absolutely. Of patients who go to government facilities, according to the government's own study, only about 60% are even given a prescription. Why that number is so low, I don't know. In the private sector, it's about 95%. They're given something, even if it's palliative treatment. But of those 60%, only 50% of them actually get the drugs. They're just not available in the hospitals and the dispensaries. So it's no good to say that NHIF is going to pay for all this if the actual service is not available, if they can't get the x-ray because there are no x-ray films, if they can't get the lab test because they have no reagents, if they can't get the consultation because there are inadequate numbers of medical personnel. And I think first you have to have the services in place.
Yeah. Let me say
Take the 10 billion shillings
Yeah.
and buy drugs with it. You'll do a lot more good for everyone in the country than
putting
it into NHIF.
Let me say that as we pay the contribution for the outpatient cover, already we have more than 315 private health facilities, including Diana's, who would like to offer this care. For them, the drugs will be there. They will get it from meds. Then we have another 400 public health facilities who will get it from KEMSA. The reason why there has been shortage is that there was not enough resources to buy those drugs. Now, if we increase the contribution, we are going to have a direct dealing with meds, with the facilities, and essential drugs will be available.
I think that tells us actually that the Ministry of Health itself needs a complete overhaul. The money that's being spent on studies, on seminars, on big
Parking
buildings, on all sorts of things that probably shouldn't be done, should be put to these purposes. That somebody should go in and try to make that ministry efficient and effective and give services to the poor. If I have to pay additional tax, knowing that the money that I pay is going to take care of a poor person or a number of poor people and give them care, I would be happy to do it. But I think people's problem now is they're paying into this scheme and they don't see any benefit for anyone.
What are the guarantees? Because if people are paying into the scheme, they want to know that there are guarantees, because first of all, this will be mandatory. If it does go through, the proposals will be mandatory. So what are the guarantees?
You know, we have three sets of contributors. We have those who are in formal employment that will pay according to the legal frame that is there. But we also have the informal, where they pay voluntarily. In fact, they can choose other existing private insurance firms, but they are not choosing. They cannot afford. It is too expensive for them. So to say that we give people a choice to choose is not correct, because for as long as NHIF has existed, then groups like AAR and, Madison, they have also existed. But there was a big barrier and people never accessed them. And to say that we wait for the government to provide drugs, if you look at the Kenya Demographic Health Survey today, the latest, you will find that only 42% of the Kenyan women who are expecting babies go to deliver under skilled attendants. Why? Partly because of the cost. They cannot go to the high-cost hospitals, and you need a scheme that could guarantee access to affordable care